Welcome to AETCM, the Emergency Medicine channel. A 47-year-old male patient came to ER with history of binge alcohol intake for 1 week, and then he presented with complaint of general tiredness, loss of appetite, slurring of speech, and tremors after stoppage of alcohol intake since 3 days. On initial 10-second assessment, patient was conscious, obeying commands, but disoriented. On primary survey, airway was patent, breathing part, saturation was 99 in room air, bilateral equivalentary, respiratory rate 18 per minute, circulation part BP 160/100, heart rate is 72, all peripheral pulse equal, disability was E4, V5, M6, and pupils bilateral equally reactive. GRB is 200. Adjoints to primary survey, we taken VBG and ECG. ECG showing normal sinus rhythm, and VBG there is no acid-based disorder.
What was patient's presenting complaint?
Slurring of speech, tremors, general tiredness, decreased intake since 3 days after stoppage of alcohol intake.
Binge alcohol intake.
Since 1 week binge alcohol intake, families stopped the alcohol intake with family support. Then patient started this complaint. Patient admitted outside the hospital, referred from outside the hospital with an episode of seizure also. Patient went to outside the hospital with these complaints, admitted outside the hospital. After 2 days, patient went into a seizure. They take an MRI. MRI was normal. Then after that, patient had pancytopenia. For further evaluation, patient came here.
Okay.
After some time, patient again went into agitated and restless. Then we managed with injection midazolam, benzodiazepines. 2 mg IV was given. Then initially we keep the patient in NPO because initial withdrawal period there is a chance of aspiration. So we kept the patient in NPO. Then we started on benzodiazepine. First line drug of therapy.
Finish the case. Other things we will finish. You told till primary survey, right? So history part and then it's secondary examination you
secondary systemic examination, patient with systems hold within normal limit. There is no any motor deficits. Then initially started with benzodiazepines and IV fluids. We checked the lab routine for any electrolyte imbalance.
What electrolyte imbalance are you expecting here?
Patient hyponatremia, hypomagnesemia, hypokalemia.
If hypomagnesemia is there or hypokalemia is there, what do you infer from that? What do you mean by it, or what is the use for it?
Patient, there is chance for arrhythmia. Or patient
is there for every patient. No? So this patient, what is the age of the patient?
47.
47-year-old patient presents with 1 week history of binge alcohol intake. Suddenly stopped 3 days back. Post 3 days, patient developed
tremors,
tiredness and tremors. He was admitted in outside hospital for how long?
2 days.
For 2 days. So after stoppage of alcohol, after 24 hours, patient developed agitation and tremors. Was admitted in outside hospital for 2 days, then referring to us because after 2 days, patient developed one episode of seizure
and pancytopenia.
Okay, fine, pancytopenia. Now, on arrival, patient is conscious, right? Patient is conscious, oriented.
Obeying commands, not oriented.
Obeying commands, not oriented. So, disoriented patient.
Hallucination also.
Primary survey is clean. Primary survey, there is airway, breathing, circulation, all things are clean.
Circulation part, there is hypertension. The patient is not a known case of hypertension.
160/100. 160/100 with a heart rate of 72. So, at this point of time, what is your primary diagnosis? Your secondary clinical examination is negative, right? Your history was there is no fever, there
fever.
is no respiratory distress, there is no cough, sputum production.
Nothing. No infective. No.
So only history is chronic, means acute binge alcoholism with the stoppage 3 days back. Secondary examination is clean. So what is your diagnosis now?
Patient is in alcohol withdrawal syndrome. So.
Okay. So you are saying this is alcohol withdrawal, which is one of the acceptable DDs. What else?
There is no any history of fever, and so we can rule out like meningitis, encephalitis.
Okay, since no history of fever and young age without any comorbidities, we can rule out immunosuppression, so we can rule out meningitis.
Other thing we can like a hypertensive, so any IC bleed, intracranial bleed, or CVA.
Even if his BP is 140/90, will you suspect IC bleed?
Patient is noted.
Yeah, his BP is 140/90. 49 years, 140/90 is acceptable. No, so like more than 45 years, there is a possibility of primary hypertension. This is 49. BP is 140/90. Will you do neuroimaging or not?
To rule out, we will.
What to rule out? What will you rule out?
Any intracranial patient also, along with this altered sensorium, we will rule out any intracranial bleed or stroke.
Why? Why a neuroimaging is important in this patient?
This patient is, there is a history of alcohol intake is there, but without ruling out that thing, we will.
Patient has given a history of binge alcohol ingestion for past 1 week, right? A patient already on alcohol for 1 week. Can you rule out trauma?
No.
Can patient tell you trauma history? You don't know whether patient was conscious enough to understand a trauma, right? So patient could have, under the influence of alcohol, got into any slip and fall or any gait disturbance that causes a fall. Patient might be having cranial bleed. SDH can be there, which is slowly progressing over last 5 days. Can develop like this, right? Patient had a seizure also. Because of that, neuroimaging is required. What neuroimaging? You need a CT. You need a CT brain to rule out IC bleed. Because it's mainly because you can't rule out trauma. It's not because patient's BP is over 160/100. It's mainly because patient, since under alcohol, you can't rule out trauma history. Bystanders was not there. It's not witness. He was under influence of alcohol. These things. Okay. So neuroimaging need to be done about that. But so DDs are alcohol withdrawal, then trauma-induced intracranial injuries, then what else? Binge alcohol ingestion for 1 week. After that, patient becomes altered behavior, tremors, seizures.
Alcoholic hepatitis causing hepatic encephalopathy.
Alcoholic hepatitis can cause altered behaviors. Hepatic encephalopathy is a correct answer, but rarely seizures. Hepatic encephalopathy doesn't usually present with seizures, but can present. But yeah, we can keep it like that. What else? But then patient will have right-sided abdominal pain, multiple episodes of nausea, vomiting, isn't it? Anyhow, we can keep that from history part. What else? Wernicke's encephalopathy. That is true. Patient suddenly stopped alcohol, started having normal food because family intervention can develop Wernicke's encephalopathy. But Wernicke's encephalopathy usually is found on deficiency patients. That means patient should be chronic alcoholic, not acute alcoholism, chronic alcoholism. So over time their internal reserve is finished, and when patient suddenly gets disposed without timing, patient goes into Wernicke. But yeah, we can keep Wernicke's because this patient is giving history of binge. What is preventing the patient from consuming alcohol previously? The patient could have been consuming alcohol without telling the bystanders, no? They may not be knowing. This 1 week he was uncontrolled. That's the only thing. So if a patient is, a history of alcoholism is there, chronicity we should expect. What else? What are the DD?
Hypoglycemia, hypoglycemic seizures.
It can be hypoglycemia as such. Post-alcoholism, patient can usually, especially after binge alcoholism, patient's oral intake will be reduced because alcohol is a potent gastric irritant. Patient can go into gastritis. Food consumption will worsen that. patient usually won't take anything orally. Patient can go into hypoglycemic episodes. But over 3 days is the thing that is against hypoglycemia. 3 days patient was admitted in outside hospital. So it was hypoglycemia, already would have been found out and treated. What alcohol he was taking? He took alcohol for 1 week. What is the type of alcohol? Any importance is there for the type of alcohol?
Sugar, like calorie content to it.
Ah.
Whether he's in starvation or he's able to reach it.
Yeah, so depends on whether it's hard alcohol or beer.
Yeah.
So if it is beer, it can very well be hyponatremia because beer causes lot of sodium dosage from the body. So it can be very well be hyponatremia. If unless outside hospital has evaluated, patient will be having hyponatremic features. So hyponatremia is important in this condition. So these are the main DDs right now that we are having. Fine. So how can you say this is alcohol withdrawal? So what are the prerequisites that you require to diagnose a patient to have alcohol withdrawal?
Initially, we can take from history, patient has a history of alcohol, binge alcohol intake, and after stoppage.
So if there is no binge alcohol, you won't suspect alcohol withdrawal?
Yes.
So chronicity or binge alcohol? Question is whether patient was consuming alcohol regularly. That is the question.
And symptoms are appearing with stoppage within 5 to 6 hours.
6 hours. From 6 hours it can develop. From 6 hours it can develop. But usually it is 24 hours post cessation of last alcohol drink. Usually. But from 6 hours you can develop features. So that is there. What else? What other history, but what other things that will point towards more of an alcohol withdrawal?
Patient symptoms like patient restless, hallucinations.
No, those are symptoms of alcohol withdrawal. What in history can the bystanders help you to narrow the differential diagnosis towards alcohol? Previous history. Whether patient is having a previous history of alcohol withdrawal. The more times a patient goes into withdrawal, the more severe the symptoms can be and more frequent the symptoms can be. If patient's bystander is telling last alcohol drink was taken 8 hours back, but he had a binge episode, on assessment patient is still having altered behavior, or you feel patient is still under the influence of alcohol, will you suspect withdrawal? Or in other ways, can withdrawal happen when blood alcohol content is positive? Alcohol withdrawal can be present even if blood alcohol levels are positive. So, even if patient is under the influence of alcohol, if the patient is a chronic alcohol and have missed alcohol for more than 6 hours, patient can go into delirium, withdrawal, alcohol withdrawal, not delirium, alcohol withdrawal. That is why you say from 6 hours onwards, usually it is 24, but even 6 hours. That criteria is more applicable for chronic alcohol intake patients. Now, criteria of means from history, these are the things. How will you on examination, how will the patient present?
Initially, we can divide the alcohol withdrawal into 4 stages. That is alcohol tremors, that is initial stage. It is from 6 to 36 hours. Patient presented with agitation, tremors, anxiety, slurring of speech, like that. Then another stage is seizures. Seizures is GTCS, or sometimes it goes into status epilepticus. So initial appearance of patient is confused, or any tremors, or any anxiety, or any next is hallucinations. Hallucination is more is visual hallucination, then auditory hallucination, and tactile hallucination. And last patient will go into delirium tremens. Delirium tremens consists of hallucinations with agitations like autonomic function like diaphoresis, tachycardia, hypertension, fever, confusion.
So, patient develops these symptoms in a linear fraction? Like patient will develop tremors, confusion, anxiety initially, then progress towards delirium tremors, then goes into seizure, then goes into hallucination. Is it like that? So patients can develop any features of alcohol withdrawal. So classification is mild versus severe. That is the only two classification. Because the whole idea of mild versus severe is whether the patient requires IP admission or can the patient be treated as a OP case. That is the only difference this classification is going to tell us. It's not prognostic. It is just to tell us whether this patient requires oral tablets and supportive care and discharge under the care of someone who can observe the patient, or should we admit the case. So mild symptoms is what we usually see. What are the common features of alcohol withdrawal? Anxiety, agitation, tachycardia, diaphoresis, and craving of alcohol, uncontrolled craving of alcohol. These are the main features that you see when a patient initially presents. If patient is having these symptoms with mild or unlikely vomiting sensation, nausea vomiting is very minimal, then these patients can be managed in a OP fashion. Anything higher than these symptoms are there, patient will require IP admission. Now, what are the severe symptoms? Severe symptoms are
agitation, seizures,
so delirium tremens, seizures, and hallucinations. In this, it is not in a ascending fashion of severity. Patient can have hallucinations, some patients can have agitation, some patients can have delirium tremens. It's not needed that everyone should develop all the features, or if one feature is there, the other will be there. So clinically, if a patient gives previous history of withdrawal, that is the best history you can get, because previous history, how it was, usually the patients will be staying on the same level or can worsen. So if patient gives previously, I have multiple episodes of this thing, but usually it is mild symptoms, most probably the patient is going to be having mild symptoms now also. But if a patient is giving a history of previously I had an alcohol withdrawal, I had a seizure episode, this patient is highly prone to develop another seizure episode now. But that doesn't mean this patient will develop delirium tremens or hallucination. Similarly, if previous episode of hallucination is there, even now there is a possibility of hallucination. So whatever symptoms previously is there, usually patients stick to those symptoms rather than have cross symptomatology. It doesn't mean that patient will not develop, but we should be looking out for the same symptoms again. Previous seizure, even now we have to suspect seizures. Patient can develop seizures. Previous delirium tremens, well, now delirium tremens. Very unlikely, previous delirium tremens now presenting with seizure alone. Okay. Now, what is the time duration usually that we see? Mild symptom starts, as we told earlier, 6 to 48 hours. When do delirium tremens sets in?
It is take 48 to 90 hours.
Yeah, so usually delirium tremens takes more times to present itself. Up to 48 hours it can delay, but within 96 hours it should start. And once started, it can go up to 3 days. So 48 to 96 hours for presentation, and once presented, it can take up to 96 hours for resolution of delirium tremens. How much time duration for the initial seizures to usually appear? Usually
36 to 48 hours.
Yeah, so usually after 24 hours only seizure will set in. Hallucination can develop within 12 hours. 12 to 48 hours is hallucination. But even though we say these are the timelines, it's not necessary that patient will stick to these. So what are the other cofactors that will worsen alcohol withdrawal? What are the other cofactors?
Cofactors, any other drugs patient is taking?
Yes, so concordant use of other drugs. What is the most common drug that along with alcohol patients take? Benzodiazepines. Sedative is close, no? So alcohol is a sedative, benzodiazepine sedative. Sedatives go to the patient takes benzodiazepines. So patient can have withdrawal from alcohol as well as benzodiazepines, which will worsen patient's presentation as such. How will you differentiate benzodiazepine withdrawal from alcohol withdrawal? Same features. Patient's benzodiazepine withdrawal is similar to alcohol withdrawal. Usually alcohol withdrawal will cause a bit more tachycardia and hypertension, but otherwise it same symptoms is seen in alcohol and benzodiazepine. That's why it's very much needed to get a history of benzodiazepine usage or serum benzodiazepine level, because patient can be concomitantly using it without showing any other new features. So, adjacent use of other drugs. What else? Decreased oral intake, nutrition. Decreased nutrition can cause worsening of symptoms. What else? Especially with the decrease of nutrition, what are the other conditions that will prolong? Hypomagnesemia, hypophosphatemia and hypokalemia. These things can worsen patients' alcohol withdrawal as such. So, you have to look for these electrolyte disturbances. If it is there, correction should be initiated as such. So, these are the things that can worsen patient's presentation or make the presentation earlier. So, these things should be looked into. Now, coming to hallucination, as you told, alcoholic hallucination is usually visual hallucination, very rarely tactile and auditory hallucination. It's usually visual. And if patient is hallucinating, is it necessary the patient to have altered meditation?
Normally alcohol hallucination is very patient knows patient is hallucinating.
So patient's sensorium may not be affected. This is why even though we say it is mild and severe symptoms, patients need not develop these symptoms in a hierarchy way. Patient can be having fully conscious oriented patient can have a hallucination which will put him on severe symptom list, even though other symptoms might not be there. But usually delirium tremens, since it comes towards the last 48 to 96 hours last, usually delirium tremens before onset, patient will have some features of other alcohol withdrawal features usually will be there for patients. Very rarely patient will just present with the delirium tremens alone. Other features might have preceded that usually, but okay. Now seizures. Most common type of seizures in alcohol withdrawal is
GTC, yes.
Generalized tonic-clonic seizures. Very unlikely patient goes into status epilepticus, but patients can have multiple episodes of seizures. So it's not like one time. Patient may develop a seizure now, then another 2 or 3 episodes can follow simultaneously, but very rarely patient goes into status epilepticus. So if a patient presents with these symptoms, now symptomatology as such we know. What are the other things that we look for? How is the pupil in alcohol withdrawal?
Dilated.
Normal. That is one of the differentiating features between opioid withdrawal and alcohol withdrawal. Opioid will have mydriasis. Opioid has mydriasis. Alcohol may be normal to meiosis. Sympathetic activation usually. So, normal to meiosis. Opioid has mydriatic pupils. Otherwise, usually it will be normal. Pupil will be reactive to light and normal. What other? Persistent tachycardia, hypertension. Opioid will usually have bradycardia to hypotension or normotension. Tachypneic diaphoresis. Opioid will have normally normal breath to suppressed breath reports. So, opioid should also be looked into, because if patient is on alcohol, we can't say what other drugs the patient is already taking. So, look for multiple other drugs. And when you send for serum levels, if you suspect patient to have access to other drugs or bystander gives history of abuse, you should think about sending opioid and benzodiazepine levels in blood to check for concomitant use also. Now coming to investigations. What are the investigations you should send for a patient presents with these symptoms?
Electrolyte will...
As we told, we need electrolytes. It can be alcohol-induced electrolytes, for example, hyponatremia, or nutrition deficiency causing electrolytes that we told, hypomagnesemia, hypokalemia, hypophosphatemia. What else?
LFT.
Yes, as you told, it can be acute alcohol intoxication causing alcohol toxicity with alcoholic hepatitis. So, LFT levels is important here. Even if you don't send ammonia, if your OTPTs are significantly raised more than 1000, you can suspect alcohol liver injury. What else?
APTT, PTI, and
Yeah, for supportive for acute hepatitis, you can send APTT, PTI, and coagulopathy management. What about alcohol level? Any other organ important?
pancreas.
Yeah. So other symptomatology in which patient can present with agitation, diaphoresis, abdominal pain. So it can be acute pancreatitis, acute cholecystitis, acute pancreatitis. These can mimic patients with general symptoms. So if you say this patient is having withdrawal, it can very well be a pancreatitis patient also. So other differential diagnosis of other conditions should be ruled out. What else? Creatinine level. Alcohol is being metabolized in the level, then excreted out, right? So amount of excretion depends on creatinine level. So, and alcohol can cause acute kidney injury. So creatinine level is important in these patients. What else? As you told, infection to be ruled out. So CBC, CRP, as you told, meningitis, encephalitis, those reports. Then comes neuroimaging. So ideally you should get a CT brain, because more than ischemic conditions, very likely patient is having a hemorrhagic thing. You have to rule out IC bleed due to the trauma history part. Now coming to management. What is the primary management of a patient?
Benzodiazepine is the...
What is the primary treatment that should be given to the patient? Not specific treatment. What is the primary management? We told initially, when a patient is present with acute alcoholic withdrawal, what is the primary thing? Keep the patient NPO, because there is a likely, especially previous history of seizures, likely episode of seizures, so we don't want the patient to aspirate. So we can keep patient NPO for some amount of time, initial time, not specifically, because patient requires nutritional support. NPO, what else?
Symptomatic management, like if patient is vomiting, we can give antiemetics.
But first and foremost, hydration. First and foremost is hydration. Alcohol is a diuretic agent. So patient will lose a lot of water. So patients should be hydrated properly. So hydration. What else? Supportive management, antiemetics, PPIs for alcoholic gastritis. PPIs you can give. What else?
Patient is in alcohol withdrawal, we can start with the initial.
So how will you know patient is in alcohol withdrawal? Your symptomatology. Then what you do? So you got your symptoms. Patient is having agitation, anxiety, confusion, a bit of sweating is there. So, but patient is obeying commands and is responding to you. How will you decide what type of alcohol withdrawal treatment you want to give to this patient?
We can scale with bedside scaling, like predictability of alcohol withdrawal severity scale.
Now, what is that scale called as?
PAWS and Shias and pauses.
Most commonly used one is Shiva's score. Shiva's score is, full form of Shiva's score is? Clinically institutional assessment.
Clinical Institute of Withdrawal Assessment of Alcohol and Reversal.
Okay, reversal. Shiva's -AR. Right? Shiva's alcohol reversal. Yeah. Okay, so Shiva's score, you have multiple headings in it and you can score according to patient symptoms. What is the problem with Shiva's score?
If patient in altered sensorium, we cannot...
Patient cooperation is very much needed. Without patient cooperation, you can't use the scoring system. So basically, Shiva's score is not required for severe symptoms patients. Severe symptoms is clinical assessment. Only mild symptoms use Shiva's score. So you get a chronic alcoholic patient. Okay, chronic alcoholic patient is there. You check Shiva's score. Shiva's score is coming 8 or 10. Will you start alcohol withdrawal treatment for him?
Shiva's
if
score
there is no symptoms.
10 is mild score. So
no symptoms. Patient is fine. Patient just came to you saying that I want de-addiction. So you did a Shiva score. Shiva score is showing 10. More than 8 is mild. So 10. Patient doesn't have any complaints as such. Will you start de-addiction treatment?
You can give oral medications.
You should not. Shiva score should not be used to diagnose withdrawal. So withdrawal diagnosis is purely clinical. The severity assessment is with Shiva score. Okay, and Shiva score severity assessment is usually done for mild cases in which we can assess whether the patient requires IP or OP. Even if in OP cases we can do, but more severe like seizure history, delirium tremens, hallucinations, we don't have to use Shiva score because patient's response cannot be trusted in those conditions. Because patient is hallucinating, patient can be delirious. So without patient cooperation and full history, you can't score Shiva score. Okay, so but scoring system usually use this Shiva score as initial assessment. So you can use a scale to see what level the patient is on. Then how will you manage alcohol withdrawal? What is the drugs for alcohol withdrawal?
Alcohol withdrawal, initial first line drug is benzodiazepine. We can use diazepam or lorazepam.
Okay.
If you use
Why not midazolam?
Midazolam, it is short acting.
So?
We can need long acting drug
Why?
because patient withdrawal is prolonged, so we will the dose also in high dose we needed for long acting.
So basically you want a continuous serum level of drug. So you give shorter drugs like midazolam, you will have multiple drug dosages in between. It's better to give long acting benzodiazepine, as you told.
Lorazepam.
Diazepam, because diazepam once metabolized, the metabolite is also active metabolite. So that will also continue the sedation. So best drug for alcohol withdrawal is diazepam. What is the dose?
It is 5 to 10 mg IV given every 5 to 10 minutes.
Till?
Till
When will you stop? 5 to 10 minutes you are giving IM. When will you stop?
clinically improved.
When patient is sedated. Patient is sedated. That is so patient should be awake, arousable, but should be sedated. Arousable sedation is what you aim at. What is the complication you should expect in a patient who are given diazepam or lorazepam? Respiratory depression. So respiratory effort of the patient should be assessed periodically. Now, what type of patients is given lorazepam? You told lorazepam, no? Diazepam or lorazepam is what you told. What type of patients lorazepam is important?
Liver failure patient.
Liver failure. Why lorazepam is preferred in liver failure patient and not for every other patient?
More in no hepatic metabolism, more in renal
Benzodiazepine is metabolized by liver. So, long-acting diazepam will have much more longer action. Activity will be prolonged in case of liver injury. So, you prefer lorazepam, which will have much lesser duration of activity, and there is no active metabolite for lorazepam metabolism. So, dosages may be frequent, but patient will not go into oversedation and respiratory depression. What is the preferred route of administration for benzodiazepine in acute alcohol withdrawal? Not mild, severe symptoms.
IV.
Why not IM?
It is more time to take for action.
Not only more time, amount of absorption cannot be predetermined. Patient can get sedated, patient may take a longer time to sedate, but the constant drug is being absorbed from the IM side, no? So, final sedation levels cannot be estimated initially. So, preferred is IV, because you know there is the amount of bioavailability and amount of absorption for the drug. So, preferred is IV. In mild cases, you can give IM. Okay.
Then
So,
if patient is refractory to benzodiazepine, we can use barbiturate, phenobarbital.
What is the dose?
150 to 250 milligram IV we can use.
Yeah, but then airways should be
I should maintain
supported for the patient because it will cause significant
sedation and
sedation.
need for intubation.
So, what if this patient, you have a patient who takes benzodiazepines along with alcohol? Will you start phenobarbital as an initial drug of therapy? You should start the patient on benzodiazepine alone. Phenobarbital should always be secondary to refractory to benzodiazepines. Should not be used as a first line agent. Okay. So, hallucinations, delirium tremens, fine. So, seizures. So, this patient develops seizures. Think that outside hospital he had a seizure, no? You are managing this patient. Patient develops seizure episode. How will you manage?
First of all, we keep the patient to left lateral position. If any oral secretion is there, suction the oral secretion, put on oxygen supplementation. Then we start with benzodiazepines, lorazepam, and midazolam can try.
In that case, you can give midazolam because midazolam have the shortest onset of time. No, so you are trying to stop the seizure. You are not trying to treat alcohol withdrawal. So for that, you can give midazolam because you want termination of seizure. Then patient after midazolam, patient reverted, but after 20 minutes, 30 minutes, patient again goes into seizure. How will you manage?
We can move on with the benzodiazepine because anti-epileptics there is no such effective on alcohol withdrawal seizures.
Yeah, basically any toxin-induced seizures, anti-epileptics have very minimal role. So any toxin-induced seizures, you really don't want to start anti-epileptics. You can manage with benzodiazepines alone. Okay. Then
if patient is also refractory to benzodiazepine and barbiturate, we can also give propofol. So propofol while giving, we will plan with intubation also.
What about ketamine?
Ketamine increase the ICP and it also
Patient CT was normal.
chance of seizures, ketamine.
I believe ketamine infusion is one of the drugs for status epilepticus. You told what are the severe symptoms of alcohol withdrawal?
Hallucination, hallucination.
Hallucinations. Ketamine should not be given. So hallucination patients, that's why schizophrenic patients we should not give ketamine. No? Patient can hallucinate and that hallucinations can be worsened. So for that ketamine is not preferred. Propofol and benzodiazepines are the most common drugs that we give. Okay, what else? Anything else? Alcohol withdrawal.
Alcohol withdrawal, there is front loading of drugs. That is, initially then we can give more dose of drug, and basically that's given old age patient with comorbidities. That is front loading of drugs.
Anything else? Patient presents to you. This patient presents to you 5 days after alcohol, binge alcohol ingestion. 5 to 6 days of binge alcohol. Patient had 1 week of binge alcohol ingestion. After that, patient was at home. He was doing fine and all, but suddenly and then progressively patient became drowsy, altered and all. He is presenting to you on the 6th day. Patient is in mild altered behavior, confused, some tremors are there. Your Shiva score is 5. Will you say it is alcohol withdrawal?
Clinically,
after 5 to 6 days, it's very unlikely to be alcohol withdrawal. That's what initially when we told the symptoms. No, it can start any time between 6 hours to 24 hours and it can last up to 3 days, 96 hours. 3 to 4 days, 72 to 96 hours. But usually after that, it's very unlikely a previously asymptomatic patient develops alcohol withdrawal. A alcohol withdrawal that initially developed can continue. For example, patient developed alcohol withdrawal within 24 hours. After next 24 to 48 hours, patient developed delirium tremens. That delirium tremens that can then go on to next 3 to 4 days. So total duration of withdrawal can be 5 to 7 days. But after 5th day, 6th day, patient developing new symptoms usually won't be due to alcohol withdrawal. It should be treated as something else. And once all other differential diagnosis is ruled out, then only it should be attributed to alcohol withdrawal as such. Okay. Anything else? Hello.